Hi, it's Jessica DeMassa with WTF Health. I'm here in the HISIS studio here at HIC 2019, and joining me right now I have Tom Skotnicki. He's actually somebody who is involved in the precursor to what has become the Australian Digital Health Agency. He currently consults in the space and e-health, m-health, digital health, and he's a patient. He's received a liver transplant just a few years ago. Tom, it's great to have you with us. Thank you for talking to us.
Thanks, Jessica. It's been an amazing journey in terms of digital health in Australia. I mean, I became an external consultant to what was then NETA, the National E-Health Transition Authority,
Okay.
and which eventually became the Australian Digital Health Agency, which is now responsible for digital health policy in Australia.
All right, so weigh in for us. I mean, as somebody who was there from the beginning to what it has grown to now, I mean, what do you think?
Well, you know, I guess my concern is that when we started off a decade ago, we approached it with enormous enthusiasm. And there was a lot of funding from government, literally billions of dollars have been spent on it. And there was the hope at that stage. I actually recall the mantra that was used, which was right information, right place, right time. That was the mantra that was used to sort of talk about, you know, the opportunity that existed to get digital health to provide care connectivity between, you know, different practitioners and on behalf of patients. The reality has been that 10 years later, that we've made progress, but it really hasn't been to the extent that anyone would have hoped for.
So are you disappointed?
Look, no, I'm still hopeful. I'm hopeful that we can progress further. I'm hopeful that we can get to the point where I've had, for example, 90 pathology tests since my liver transplant 2 years ago. So far, not one of those pathology reports has appeared on my health record, which is the government, you know, provided health record. Not one imaging report has appeared on my health record. The only thing that I can really access from my health record at the moment is information about my doctor's visits and pharmaceuticals. Well, that's better than nothing.
Yeah.
And eventually, I am confident that they will be able to upload my pathology and imaging into the future. But I mean, my hope for digital health goes a lot further than that. You know, I actually want to see a situation in which I'm also type 2 diabetic.
Oh gosh. Okay.
I would hope that we get to the point eventually where, as a type 2 diabetic with a health record, that if I haven't had a HbA1c for 6 months, that I receive a notification through my health record, either by email or text message, to say, hey,
time to get this done.
Time to get this done. I'll give another example. I mean, having had a liver transplant, I had cirrhosis of the liver for 15 years before I got my transplant. In fact, my transplant was precipitated because I was in hospital with sepsis, and just coincidentally or incidentally, one of the doctors decided that they'd do a gastric scan, and they actually discovered tumours on my liver.
Goodness.
So, despite the fact that I'd had cirrhosis for 15 years, for one reason or another, and this is just the gaps in the system, neither my GP nor my gastroenterologist, and I had the same gastroenterologist and the GP for the full 15 years, neither of them had sent me for a liver scan or imaging for more than 10 years. And by the time I had it, the cancers were so far developed, were so big, that I was told that they are inoperable, that I wasn't a candidate for a liver transplant. I wasn't even a candidate for a thing called transarterial chemoembolization, which is the sort of standard treatment for liver cancers. I was lucky in the sense that eventually I refused to accept the diagnosis or the conclusion that they drew, and I went off and got second, third, fourth opinions, and eventually was able to get the transarterial or TACE treatment, which eventually shrunk the cancer sufficiently that I qualified for a liver transplant.
Wow.
But it shouldn't happen. Those sorts of the future of digital health, the promise of digital health, is to help prevent some of these gaps. To fill in some of these gaps.
In terms of the practical execution of that, how do we get to that system that does fill in those gaps? Because, I mean, when you started talking about your experience with NIDA, you said it was more than $1 billion in funding. So, I mean, that's often the thing that's looked at. Well, we don't have the money. We don't have the technology. I mean, where are we now? What do you think it is that's stopping the My Health record from living out the full potential that you see for it in that vision, or even some of these other digital health solutions that could be implemented? I mean, what do you think is stopping it?
Well, I think, first of all, we have to fully populate the health records. So my experience where pathology reports and imaging reports are not there needs to be rectified. In addition to that, you need to be able to sort of apply the sort of artificial intelligence that really is already available to those records, so that you can get sort of a notification system in place. It's not that difficult. I mean, it's not rocket science, it's computer science. But it's I think from my point of view, I have to say, and I won't be very popular with some of my clinical friends, but from my point of view, I tend to think we have a system in Australia which is largely a universal health system, which is largely government funded. And my view is that that any medical procedure that receives a government rebate should mandatorily be uploaded to the My Health record. And obviously that's not going to be popular with people who aren't doing it at the moment or don't have the technology available. But I think unless you sort of say, well, look, we're going to impose this, even if it's saying, well, look, within 5 years, every single procedure, medical procedure, is going to be uploaded, then it won't happen. And if it doesn't happen, then we're missing out on an opportunity. I contrast that. I was talking to an oncologist from Croatia the other day, and she was saying to me, well, that already happens in Croatia.
Really? Okay. So it's tied up to the reimbursement.
Well, no, it just happens because
that's how they do it. Okay, so they're not even having to be just tying it up with reimbursement.
It's just a requirement on medical professionals, their clinicians, that they upload to the government health record. But in Australia, I think I mean it's basically, I can see it being tied up to the funding. Whether you do that through a carrot or a stick approach, whether you have to introduce an incentive to start with, and you say, well, okay, we'll start off with an incentive, and then we'll sort of simply provide a cut-off date from which it's just mandatory. And if you don't do it, then your patient will not qualify for a rebate. I think you'd very soon find that at the moment, look, I would guess, and it is a guess, but I'd say less than 5% of specialists in Australia are uploading to My Health record. And I'm sure they'd be resistant to any change, but I think you'd very soon get up to 100% if you said their patients couldn't get a rebate if they weren't doing it at a certain point. I mean, if you gave them, and if you assisted them in terms of getting prepared with, sort of incentives to purchase the technology and so forth.
Okay, so really interesting point of view about tying the My Health record to whether or not the patient gets a rebate. and that's kind of counter to what I've been hearing. So what I have been hearing a lot from the folks that I've interviewed from the Digital Health Agency here in Australia is that no, the uptake for the My Health record is really going to come from patients and healthcare consumers demanding that their GP and their specialists put all of their records up there. Do you think that there's any merit to that claim, or do you think that we're putting too much of our hopes on the population here, the patient population, the consumer population? What are your thoughts on that?
Well, I first heard something similar to that 10 years ago from the then director of the Department of Health and Ageing here in Australia, and it hasn't happened in the last 10 years, despite the fact that we've had first of all, the personally controlled electronic health record, the PECA as it was called, and since then, of course, developed or transformed into the My Health record. The fact of the matter is, I think that to some extent that there is a certain amount of truth. I mean, you know, individual doctors, individual patients will respond, I think, to the opportunity that exists to try and sort of expand digital health. But it will be at a very slow pace.
Yeah, I was just going to say.
And I mean, you know, where the utilisation rate is so low at the moment, the whole idea is we want. Look, I don't think My Health record will ever be a clinical tool in Australia. I don't think so. No, I really don't. Not even if it was fully developed. However,
why not?
Well, because basically the job of a clinician is to interpret, you know, what's going on and to talk to the patient and extract information from the patient. Sure, look, you might get to the point where they're doing it with the, you know, My Health record in the background, but, you know, the problem is curation.
Yeah.
You know, I'm a chronic and complex patient. I have, you know, I see a cardiologist, a nephrologist, you know, an endocrinologist.
So the amount of data you have in there is just going to be...
So basically, you know, it's only through interrogation, well, you know, if you want to call it that, but, you know, it's you know, only through querying me that they're going to get to a sense of exactly what's going on and what my concerns are.
So is it worth the expense and the time and the effort to get the My Health record up and running?
Absolutely.
Okay,
absolutely. No.
And for what purpose, if not to be a clinical tool?
Well, because it's still, I think it'll be a clinical tool. I said critical clinical tool.
Okay, got it.
I think it's going to be, but the promise is that it'll be an adjunct clinical tool.
Got it.
So, I mean, you know, it still gets to the point where, you know, if you're going in to see a nephrologist after you've happened to have had a blood test or pathology done 2 weeks earlier.
Yeah.
Some of which will be relevant to the nephrologist who's worried about your kidneys or whatever. Then sure, you know, I mean, he's going to look at that or she's going to look at that, and they're going to say, well, okay, you know, there's value in that, and I can see, oh, look, I can deduce this from that. But as I said, that's an adjunct use. It's not. And look, as for on a daily basis, when you're dealing with your GP is just going to look at, you know, if they're referring to a health record, they're just referring to their own, you know, their own clinical record or case record that they've got on you anyway. So it's only in those circumstances where you're sort of moving to, you're basically seeing somebody on an occasional basis or in a different location or whatever, that it really assumes a more important function. And
really interesting. I mean, such an interesting perspective on the utility of the My Health record, and also, I mean, longitudinally, like, I mean, from the beginning. So, Tom, thank you so much for your time. Real quick, just to let everybody know, how are you doing right now? I mean, as far as your cancer is concerned,
I'm really
everything, liver transplant.
You know, it's sort of everyone has health issues.
Yeah,
but,
you doing okay?
I'm doing really well.
All right, good.
I'm doing really
Happy
well.
to hear it. Thank you so
Thank
much
you.
for stopping by. Thanks so much.
Bye.
Bye. I'm Jessica DeMassa with WTF Health here at HISA Studio at HIC 2019. Thanks so much for joining us.